Well, thank you so much. It is such a treat to talk to you both, the folks in person and those who are virtual. It is a real treat. And so I'm gonna, Sharon invited me to spend a few minutes. I'm gonna talk for probably about almost a half an hour, but we can do longer or shorter as you guys like. But I really wanted to give you guys a little outline of what we do in Toronto and what you guys have helped us do, because I've never really done this before. This is my first time kind of addressing the CPFF directly, and it is such an honor after the time that we spent together, really, because what I wanted to tell you about today, I'm advancing, is that I would argue that, my talk today is really a paradigm of a successful partnership and some of the great work we've done together. And so before we kind of talk about what the CPFF has done, which is where I'll spend the bulk of my time, I thought it might be worthwhile to kind of tell you guys my story. Some of you kind of know my story, although I don't know if anyone really knows my real ILD story as it was told. And I think it's important because although I'm going to keep talking about things that I've done, at the same time saying that none of it is thanks to me, it's all thanks to me and my partners, including you guys. But I do think that it's the place that I came from that helped me to be where I am now and to help the Robert Davidson Fellowship become what it became. Because I was actually the first ILD fellow, for sure the first ILD fellow in Ontario. I'm not sure if I was the first ILD fellow ever to train in Canada, but I was the first one. It was in 2009, and I got funding called the Cameron Gray Fellowship. So this was funding that came from a Dr. Cameron Gay who, when he passed, he left money to do a fellowship through the Ontario Thoracic Society. And the Cameron Gray was a really interesting fellowship funding. Essentially what it was money for someone to train to do whatever they wanted, as long as it was felt by the committee to have merit. And so every year, each university in Ontario was allowed to put forward one person that they would nominate from the university for that funding, and then the OTS would decide which school got it. And so I was honored to have received the Cameron Gay funding. Unfortunately, that money basically completely died during the 2008 financial crisis. So I was one of the last recipients because the funding dried up, and we tried to regenerate it but weren't able to. And I think knowing about Cameron Gay Fellowship is really helpful because it shows how much things have changed from back in 2009. So what did my fellowship look like? So essentially, this was a self-directed clinical training program. So at the time, there was no ILD program in Toronto, and there were 3 doctors in the GTA who were willing to accept second opinion referrals for ILD. There was Charlie Chan, Matthew Binney, and Ted Maris. It should be noted that none of them had ILD training, but they were sort of the 3 people who had put up a placard and said, I've done enough of this that I'm willing to accept I'm willing to accept second referrals. And so what I did, and they used to just sort of sprinkle ILD into their regular clinic day, right? They would see cough and whatever, but then they would have some ILD referrals in there. And so what I did is I sat down with Charlie, Matthew, and Ted and said, what you're going to do for me, and I phrased it like that, what you're going to do for me is you're going to make sure that there are ILD patients for me to see on this day of the week. So I used to do ILD clinic with Charlie on Mondays at Toronto General. I used to do clinic with Matthew on Tuesdays at St. Michael's Hospital and Ted at Wednesdays at Toronto Western Hospital. And they would get me ILD patients for the day I was there. As you'll notice, though, there's no research time in there, right? That was 3 days a week of seeing patients. And so what was I supposed to do with the rest of the time? So the rest of the time, I was supposed to earn enough money to eat, is the answer. So I actually did the math. And so the Cameron Gray Fellowship Award paid me enough money to be the equivalent of $15 an hour. So just to remind you where I am at this time in my life and career, I am in my early 30s. I have been a resident, so a fully trained physician for 7 years, and I'm getting paid $15 an hour by the Cameron Gray Fellowship. And so what that meant was not only did they not pay me enough to eat, but it was actually part of the agreement that I had to show that I was going to do enough clinical work for the other 50% of my time to be able to meet the university's minimum requirements for what is considered a living wage. So what that meant is I had to do clinics at least 1 day a week. I used to do it Thursday and Friday, but sometimes just 1 day a week. And then I had to do moonlighting. I had to work a 14-hour shift, usually at St. Joseph's Hospital in the emergency room, one Saturday a month. So I was working while I was training, and there was certainly no time for research. But what did happen during my fellowship that was not just great about the clinical training is I went down to San Francisco for about 2 months. So Toronto General Hospital wanted to create an ILD clinic, and they said, where could we send you so that you can learn something fresh that's not just inbred from Toronto? And I said, let me go down to San Francisco because it's going to be warm. It's not warm. I had to buy a whole new wardrobe when I arrived. I was freezing. But I took my wife and my young son at the time, and we went down to San Francisco for 2 months. And the reason that this is so important is because life is all about what happens when you're doing something else, right? And so it just so happened that during the 2 months that I was down in San Francisco, a young trainee named Chris Ryerson was also in San Francisco doing his fellowship. We had never met before. We didn't even actually know that we were both going to be there at the same time. We didn't even know each other existed. But we spent 2 months down there and became fast friends. We were both the two Canadians. We developed quite a relationship. And he actually had his wife was there and his young son, and we used to hang out and take the kids to the park, to Golden Gate Park together. And although certainly, as I say, so many of the things that have happened since then in Canada are due to so many people, it is unbelievable how much having two young people who are just coming out of their training, who are really motivated, who like each other, and who live on other sides of the country, helped to create these cross-country relationships that fed into the ILD world. So I came back in 2010 and I was told to start an ILD clinic. So here were my principles. I wanted to create a tertiary referral center, which didn't exist. I wanted to have multidisciplinary diagnoses and discussions. I wanted to give patients access to education and clinical trials in Toronto, which again didn't exist. I wanted to produce a cohort for research, which subsequently became the CarePF research. And I wanted to train residents and fellows. I had seen what my training could do, and I wanted to do better. So the first was to put together a team. This is my team. You may have met some of these folks. To be honest, I'm sort of the face of the clinic. Everyone else kind of likes to see patients, and they like me to be the face of the clinic. But they are all fantastic, and every one of these people brings something slightly different to our group. So I am the administrative leader. I don't do research myself, but I am sort of an idea guy and an admin guy. Matthew Binney works both in the ILD program and also does lung transplant, and that's really his core area where he brings expertise. Ambrose Lau is an occupational medicine expert. So he does things like occupational asthma, so people who get asthma that gets worse at work. But similarly, he works with people who have asbestos exposure or who get workplace exposures, and he helps with WSIB claims and is really I would argue he's like the Dr. House, right? Because he's the one who can ask you questions about what's hiding underneath your bed sheets and find the mold that's there. Lee Fiddler and Jolene Fischer, I'm going to talk about what they're doing later because they're actually Robert Davidson success stories. One of the first things we did after we recruited our team was we hired our nurse, who initially was a nurse, and during her time with us, she trained to become a nurse practitioner, and so she's now an NP. Our nurse does a lot of really amazing things in addition to one-on-one patient education, which I think is one of the most important values of a nurse, not just in the clinic, but when the patient calls and says, I don't know what to do with my drugs, I'm having this side effect, I've got COVID, what do I do? She answers telephones all day. She also has coordinated our support group, which I'll be honest, struggled a little bit since COVID, but we're hoping to rebuild. But we kind of lost our whole group, and we've been sort of putting it back together. On the bright side, I've been hearing about the great work CPFF has been doing, and to be honest, that's been one of the challenges, is that our folks are getting great work from you guys in their support group, which isn't a challenge for anything. It just is we're going to sort of see what we can do to be value added now that you guys have found this really nice. Exactly. Now that you guys have found this really wonderful niche where you're adding real value across the country. And then finally, she helps us with our drug applications and complications. It sounds like a silly thing to think that she's reviewing blood work, but we're what I think is the largest ILD program in Canada, just because we're the only one that has 5 docs. At the moment, we have almost 250 people on antifibrotic drugs, and we have about another 500 people on other immunosuppressant drugs. Each one of those patients needs to have monthly blood work. You can only imagine the volume of paper that that goes through, and Mandy takes care of all that for us. Mandy Sivananthan. The next big thing that I thought we needed to do was create partnerships with radiology. So the concept of MDD is something that you guys are all familiar with, these multidisciplinary discussions. But, back in 2010, that was a very novel concept. And it was early in my window where I sort of said we should have weekly meetings with radiologists. I found some radiologists who were willing to collaborate. At the beginning, it was sort of a if you build it, they will come kind of philosophy. So in the room, it would be me, maybe one or two other respirologists, maybe one or two other radiologists. But over time, we built, and eventually we were having, 8, 10, 12 people who would come every week. COVID was not good for a lot of things, but what it was very good for was virtual meetings. And so we actually switched to a virtual format during COVID, and that has been amazing for us. So our MDDs every Wednesday morning at 8 o'clock now get somewhere between 35 to 40 people who attend. So not only do we have respirologists from all over U of T, we have radiologists from all over U of T. We also get radiology trainees, respirology trainees, ILD fellows, even general internal medicine residents who have heard about it and are interested. It's available for any doctor to attend, and it's been really successful. In case you're not so familiar with why we push so hard for these MDD rounds, I can tell you from personal experience, they are amazing because they produce what I call a virtuous cycle, right? What happens is when we do these rounds, not only do we build relationships with our radiology colleagues, but they start to learn about what we need in their reports so that we can start to read their reports and say, oh, they're saying the right stuff. So I'm not sure, but I know what they really mean when they say that because they've learned what I need them to say. And at the same time, as the respirologists become better, we don't need them so much, right? I can look at a CT scan. In fact, it happens that my radiologist will sometimes page me when they're interpreting a scan on my patient and say, I think this is what it is. What do you think? Because they know that nowadays I'm as comfortable looking at those scans as they are. What also happens is as you all gain comfort and skill, the complexity of the cases that you presented in MDD go up. So this is how 15 years later, you can still get people to come every week because the level of the discussion gets better every year. So they're really an amazing thing. And I thought it was so great that I did this program that you may or may not know of. Do people know about Milder? Have people heard about Sharon knows about Milder? So this was sort of one of my babies when I started. I already thought that MDDs were so great. I wanted to spread them out. So Milder stands for Multidisciplinary Interstitial Lung Disease Discussions with Experts, done remotely. I love coming up with funny mnemonics and names for things. I love branding. And I even, helped come up with the concept for our logo. This is supported by BI. Basically what this is it's Zoom for community respirologists so that they could present their cases to us and we can give them a diagnosis. So now in 2024, that doesn't sound very novel, but I can tell you when I actually sat down with a web developer, and it took me about 2 or 3 years to develop the software to create a Zoom-like platform in 2015, it was pretty awesome and pretty forward-thinking. And this is what it looks like. So you'll have all the attendees in the bottom left-hand corner, an ongoing chat in the top left-hand corner, all the members of the panel on the top right, and then we're actually showing the CAT scans and the imaging so that all the attendees can actually see what we're talking about. And the respirologists who attend actually get continuing medical education credits. So it's not just about caring for patients, but they're even incentivized to come because they get accredited CME credits. A couple of other things that we did that you guys know well about that are less driven by me, but just important to talk about what we do in Toronto is we were one of the earlier centers for the CPFF Registry, which has now become probably one of the most well-published registries in the world. It's definitely the largest registry in the world. And I was talking to someone recently that said that when I was at ATS conference last year, the American Thoracic Society conference last year, I don't think that there was a single half day that went by that my own name didn't end up on a slide where someone was thanking all of the initial creators of the CPFF Registry. That was pretty exciting for me because I'm not a researcher, but I think it should be pretty exciting for everyone in Canada to take huge pride in what Chris Ryerson and all the folks who are working on this have accomplished. We've written position papers, and you guys may be aware of these. There's 3 right now. The 4th one is in production, and I just edited my section on it where I was in charge of a weird parasitic infection that happens when people get put on prednisone called strongyloides. So we were Team Strongy, and that will be coming in the next year. We also have done clinical trials. Our center has participated in a lot of both big and small trials. And this was really a goal of mine, is to bring access to these trials to our patients. And we've had a bunch of patients be in studies that have really made a big difference. So for example, one of my patients who was in INBUILD, which is the nintedanib in non-IPF ILD study, got access to drug about 3 years earlier than she would have otherwise got access to. We had been talking about lung transplant before she got enrolled in the study, and now it's about 5 years later, she's stable and doing great. So really wonderful. So that's sort of what my clinic is and what we've done. I'm going to shift gears completely and talk about what you guys have done, or at least what you helped me to do, and what a difference it's made. So some of you may remember that I was actually the recipient, I believe, of the first CPFF grant. This was in 2010. You can see the giant check. It's actually still in my office. It's in a back corner. So Sharon, if you want this giant check to one day like laminate and put somewhere, I have no idea what to do with it. It's like 6 feet tall. But I don't even think I was supposed to take it home. I think Robert asked me one time, like, where is the check? And I had no idea. But then 2 years later, it showed up in like a closet somewhere. And I was like, oh, I've got this giant check. This was a $52,000 grant given in September of 2010. So early in CPFF days. The next year, Robert came back to us and said, I want to give you another $50,000. And so at the end of 2 years, he had given us $102,000 in startup funds. And these were unbelievably formative in both my career and the Toronto group's career, or program. What this allowed us to do is we hired our clinical trials coordinator, we hired a clinical nurse, and we really started to do some research. I will say, as a non-research trained person, my first couple of ventures on my own doing research were pretty abysmal, but I tried. But I learned a lot of really important lessons. And what I really learned is that I shouldn't be doing the research. I just didn't have the time, right? You just didn't have the time to both run the clinic and do the research. So in 2012, it became clear that the CPFF was going to become a long-term player, right? It wasn't really in 2010 and 2011. It was like, I wasn't entirely sure if Robert was full of smoke or whether it was real. But when in 2012, he said, I've got another $50,000, what do we do with it? That's when I said, okay, maybe what we need to do is start thinking on a more long-term horizon if you're going to be in this game for a long time. And in particular, I had my own pet project that I wanted to make fellows, and I wanted to make them better than I was. And I have succeeded. They're all way better than I am, but that's another. 2012, Robert and I actually had several of what we kind of coined these strategic planning meetings. We used to do them at the Toronto Western Hospital. Ted Maris, who was one of my mentors and was in that check that you saw, was in attendance. And the three of us would sit down. And Robert had a lot of great ideas, but I also had a lot of great ideas. And my goal was to try and convince him that his ideas were great, but my ideas were better. In particular, what I tried to convey was that if you teach a man to fish, if you give a man a fish, you give him a fish for a day. If you teach him to fish, he fishes for a lifetime, right? And that was the concept that I tried to impart. So we wanted the training to include some sort of master's or certificate program for advanced training. We also wanted it to have protected time, right? No more moonlighting. You can moonlight if you want, but you're getting paid a salary for 5 days a week. So even if you're only seeing patients 1 or 2 days a week, you've got plenty of time to do research for me. And the concept that I was passionate about was that this would give long-term dividends, right? That by doing this kind of training, you create clinical and research expertise that will impact all areas of that person's future career, even if they don't join an ILD center, right? They will be the ILD person no matter what. It's their label to carry for life. So we have been honored and so fortunate to be the recipient of the Robert Davidson Fellowship 8 times since 2014. Now, I'm going to put you all to sleep if I tell you about every single one of these people. So what I'm going to do is I'm going to tell you about the 3 stars that have come out of the program, and then I'm going to hint at some of the amazing stuff that the others have done. So first, I need to tell you about Jolene Fischer, who has sort of become my partner in crime and one of my closest colleagues. So she was the first CPFF-funded ILD fellowship in Canada. She did a master's in clinical epidemiology during her clinical training. And her master's led to 2 publications. So those who are not so familiar with the medical literature, there are 2 of the top papers in respiratory medicine in the world is the ERJ, the European Respiratory Journal, and the Blue and White Journal, or the Blue Journal, sorry, which is the American Journal of Respiratory and Critical Care Medicine. So you're hearing me talk about the ERJ and the Blue Journal. These are the 2 top publications. Jolene published in both of them with her master's work. The first paper that she did, which was sort of my brainchild, but she took it to the nth degree, we wanted to look at whether or not getting a lung biopsy for your ILD, whether or not it mattered where you did that. So in the past, what would happen is you need a lung biopsy. If you lived in Timmins, you would just go to the general surgeon mom and pop shop and they would do a biopsy and their pathologist would report it. And we figured that that was good. I was convinced that that was not in the best interest of patients. And so what Jolene did with a really rigorous and robust analysis was she showed that if you had your lung biopsy in a place that did more lung biopsies, for every 10 biopsies done at that center per year, the 30-day mortality from a lung biopsy went down by 0.1%. So that doesn't sound like a lot, but if your center does 100 lung biopsies a year, that means the mortality is 1% lower. Well, this is a diagnostic test, right? So if I told you that you're going to do a test and you can do it in Timmins or you can do it in Toronto, and I'm going to reduce your chances of dying 30 days after the test by 1%, that is a huge important fact for you to decide, help make your decision. So we published that in ERJ. The other thing she did, which is a super clever paper, this was kind of Chris Ryerson's brainchild, was that she typed in the words idiopathic pulmonary fibrosis. Has anyone seen this paper? It's awesome. They typed idiopathic pulmonary fibrosis into Google, Bing, and Yahoo. And they did a systematic analysis of the top 100 hits on each website. And what they found was that 50% of the websites made recommendations for things that were wrong on their websites, basically suggesting that the internet was a terrible place and everybody goes to the internet. So we're trying to educate people to go to places like the CPFF website, right? Don't just go to a blog that someone makes. This was enough. It was so novel that it got published in the Blue Journal, which is, again, one of the top journals. So 2 really fantastic ones. It's actually not even done giving dividends. Just this week, I reviewed the she got adult and pediatric papers, adult and pediatric data about lung biopsies, and the pediatric version of the paper about lung biopsies is going to be published in the next few weeks. So it takes a long time. Research is slow, but we got there. She joined our group as the ILD research director in 2016. I saw the potential immediately after she finished training and said, "You've got to join me." She took over as our site lead for CarePF in 2018. She's been the recipient of a CPFF research grant, a $20,000 grant in 2019. It was a very ambitious project to look at the incidence, prevalence, and mortality of all ILD in Ontario. COVID really kiboshed this because Jolene was quite passionate about her role in contributing to COVID care. So Jolene actually stopped doing research during COVID and worked on the COVID wards and in the COVID clinic for about 2.5 years. She's now getting back into the research, but it's a slow start. So while that's led to delays, it's actually led to an interesting opportunity, because now that we're just about to cut the data from the provincial registry, we've decided that we're also going to do the most robust analysis of COVID and ILD. So while she's already finding all these people with ILD, we have data on who got vaccinated. We know who got a swab positive for COVID in the first 2 years, and we're going to do the most robust COVID analysis on ILD that's been done. So it'll be great, but it's slow. Jolene has over 60 peer-reviewed publications in her less than 10 years as an academic respirologist. And that was enough to get her invited to be the first author on the most recent CTS guidelines, which is the long-term management of patients with fibrotic ILD. Jolene has done wonderful work. The next person I want to tell you about is Lee Fiddler. So Lee was our CPFF Fellow in 2016, or our Robert Davidson Fellow in 2016. He also did a master's in clinical epidemiology, and during his master's, he took a different tack. rather than taking one or two massive projects to publish in the top journals, he did several smaller publications, which have all still been published in really reputable journals and really interesting work. His first thing was a Canadian survey. He did a whole bunch of coursework on how to do surveys. And he did a survey of respirologists across Canada looking at how we were treating ILD patients. When were we starting oxygen? If you have an exacerbation, were we using steroids? How much steroids? If you were getting worse on treatment, did we switch to the other antifibrotics? Really interesting stuff just to get a sense of where the landscape is in Canada. We also did this really neat paper that you may have seen when you saw my myositis talk for the CPFF Education Day this year, where I was very interested in looking for occult myositis, which is a kind of autoimmune disease in our ILD patients. And he did an analysis of that for us, which got published in Lung. And then he did a really nice meta-analysis and review of the role of GERD, gastroesophageal reflux, and ILD, which was published in Chest. And it's now, because it was published several years ago, it's now a little out of date, but I was really excited when I looked at something called Up to Date. I don't know if you guys know Up to Date. It's the major resource for internal medicine. I don't use it anymore because I kind of know what I need to know. I'm not a general internist. But for about 8 years, if you typed in IPF in Up to Date, Lee's paper was the top ranked article that they cited when they talked about the role of GERD and IPF, which was a really fun accomplishment. Lee joined Sunnybrook in 2018, and his role is as a quality improver. You're going to hear this QI role, which is becoming more and more important. He is cross-appointed the UHN, and he comes to our clinic once a month, so he's still part of our team. And he received a CPFF research grant in 2020 looking more at RA-ILD. I'm going to talk about that in a moment, but Lee is a couple years behind Jolene and has 40 peer-reviewed publications in his short tenure. Like, these are amazing numbers, just to give you an idea of how successful they've been. The money he got from you, he has turned into 2 different publications that I thought I would tell you about. They've both been published this year. This one in Respiratory Medicine looked at the rates of rheumatoid arthritis-related ILD in Ontario over this 8-year time window. And what he showed is 2 really interesting things. First, the incidence and prevalence of rheumatoid arthritis-related ILD has been going up over time. So if you look at this table on the top, you're seeing that there are more people in Ontario who have rheumatoid arthritis with ILD. Over time, it's steadily going up. But what's interesting is the mortality of patients with rheumatoid arthritis-related ILD has actually been going down steadily. So we're seeing more patients, but they're living longer. And this raises a whole bunch of interesting questions, but many of us think that that's because we're finally starting to maybe get on the right track of how we're treating these patients. So a success story. The other interesting piece is that you can see this bottom line. These are men and women who have rheumatoid arthritis, their mortality if they don't have ILD. So you can clearly see how much higher the mortality is in the people with rheumatoid arthritis and ILD versus those who don't have ILD. So even though it's getting lower, the mortality in our ILD rheumatoid patients is still way higher than the rest of the group. So we have a lot of work to do. So this is a difficult question to answer because the problem is we don't know what the denominator is perfectly, but we think it's probably about 10%. And there's, whereas scleroderma, it may be as high as 30 to 50%. So they get more, but scleroderma is a rare disease, whereas rheumatoid arthritis is a very common disease. This other paper, sorry, I should have read the questioning because I don't know if the people elsewhere, they were just asking what the rate is of ILD in our rheumatoid patients. The second paper that he looked at was, you can get diagnosed with ILD early in your rheumatoid course or late in your rheumatoid course. So some people get rheumatoid arthritis and get ILD in the first few years, and other people might have rheumatoid arthritis for like 10 or 15 years. And what he showed in this is a survival curve. So you can see that as the line goes down, more people are dying, right? So this is a percentage of people who are alive. And what you see is the people who get diagnosed with ILD early in their rheumatoid course die at higher rates than people who get diagnosed with ILD late. And so this, again, is a call to arms that we need to be screening these patients and finding it, because if we find it earlier, maybe we can treat them and do better. So these were two really interesting papers that can only really be done in Ontario. When I say that, I mean like around the world, right? No one else has access to data like we do in Ontario for these kinds of population studies. So it's really quite meaningful. Sharon had once mentioned, when does CPFF get the credit? And the answer is, when you fund the actual research, you absolutely get the credit. You don't necessarily get the credit if you just fund the fellow. Unfortunately, that's kind of the way it works. You don't own the fellow, so whatever they do is theirs. They might mention you, but when you fund the research, we always make sure that the CPFF gets exactly the credit. So you can see in both of these papers, there is a special section where we talk about funding, and we always give CPFF all the credit they're due, because it's because of you guys that this kind of stuff happens. The last person on this list that I'm going to tell you about is Lee Manook. I don't know if you guys know about her, but she's a new face on the scene. She is our most recent fellow, just finished in June. And so Lee completed a certificate program. Part of why I like to talk about Lee is that I think she has done fantastic and is going to be an up-and-comer. But it just goes to show you don't necessarily have to do a master's during your Robert Davidson to be really impactful. She did a certificate program in clinical epidemiology at McMaster while she was doing her ILD training in Toronto with us. And her major research project focused on people who were considered unclassifiable. It's remarkable that unclassifiable is not actually a diagnosis, and yet it is the second most common thing to be labeled with. Sorry, the third most common thing to be labeled with when you're in our clinic. Whether it's IPF, autoimmune lung disease like connective tissue disease, just below that is unclassifiable. And it just goes to show how far we have to go before we can get, if you don't have a label for it, what do you do? How do you treat these patients? And she's looking at what makes up these unclassifiable patients, what the clinical parameters are, what their CT scans look like, and what treatment they get, and what their outcomes are, so that we can try and see if unclassifiable is really a grab bag of all different things, or are there actually a couple of distinct diseases that don't yet have names that end up falling into this group. And Lee just sent me the manuscript for this research this week for editing. So it is going to become a peer-reviewed publication. This is her standing in front of her poster at ATS. Awesome. Yes, I saw the newsletter about her on that. She was recruited to Vancouver General Hospital, and she started working there as a clinical associate in the fall. So it just goes to show that, our folks are highly sought after. Only a few weeks after she finished her training, she was like moving to Vancouver. So, that's what I wanted to tell you about those fellows. So, I've talked to you about research opportunities, fellowships, petite grants, not little grants. Petite grants is just what we call the $20,000 grants. Overall, the CPFF has donated nearly $700,000 to the UHN. And so, the goal of today is to say, for you guys to appropriately be asking, am I getting a return on my investment, right? What am I doing and why? And I want to emphasize that together we have created the first generation of ILD trained clinical experts. That's different. We don't just have people like Matthew Binney and Charlie Chan who say, I'm going to see ILD. And we don't just have one or two people like me who said, well, I'm going to cobble together ILD training. I'm going to do it, but I'm trained. We have actually created a generation of people who are not just interested, but well-trained to manage ILD. We have created academic respirologists who will do ILD research for the rest of their life. Forget it. Nothing wrong with a $20,000 grant. That's amazing. You get a couple of papers out of it. But you train a Jolene Fischer and you get 60 publications over a decade. And by increasing these numbers, we have led to increased ILD expertise in our clinical sphere across the province and beyond. So to remind you, Jolene Fischer is working at Toronto General Hospital. Andrew Yoon is working at Scarborough General Hospital. Lee Fiddler is working at Sunnybrook Health Sciences Center. Nicole Sitzer is working at St. Michael's Hospital. Andre Vagon works at Michael Garron, what used to be called Toronto East General Hospital. Colin Adams is working at St. Mary's Hospital in Kitchener-Waterloo. Kelly Sun is working at Credit Valley Hospital, and Lee Manook is now in Vancouver. We are literally across the province spreading expertise. And one could argue that outside of the research, this may even save more people than the research, although the research is how we're going to get the cure. Right? So I guess the question comes is, how do we measure success? And I hope that I have sold the argument that this is how you measure success. And I will say with a chill that's actually going through me as I say it, genuinely, we cannot thank the CPFF enough for the amazing work that you've helped us to do. And I'm going to stop there.